Thank you. Welcome to day 2 of the Board of Registered Nursing's board meeting. We do have some announcements to make this morning, just as for a timeline. We were not able to finish all of the information that needed to be processed through in closed session yesterday. So we, according to our agenda, are able to wrap up any information or any agenda items that were not completed the evening before. And so today we are going to open up in closed session. Our board president will establish a quorum by taking roll, and then immediately we will go into closed session. That closed session should wrap up by 9:30. And so the expectation is we will open back up into open session at 9:30. That is a 30-minute delay for the public today, and we want to apologize for that. And at 9:30, we will begin our day 2 board agenda open session, and we will start with the Enforcement Intervention Investigations Committee report out, and then we'll move into legislation after that. So I appreciate your patience with us for allowing us to have an additional 30 minutes this morning so that we can wrap up a closed session item from yesterday. And at this point, I'm going to turn it over to our board president, Dolores.
Good morning, everybody, and welcome to day 2 of our Board of Registered Nursing Board meeting. It is August 21st, 2025, and we will take roll call to establish a quorum. My name is Dolores Trujillo. I was appointed by Governor Newsom to the Direct Care Provider role. Board Member Jovita Dominguez.
Jovita Dominguez, appointed by Governor Newsom in the Education role.
Thank you. Board Member Patricia Nguyen.
Hi, Tricia Nguyen, appointed by Governor Newsom in the public member role.
Thank you. Board Member David Lawler.
Good morning, David Lawler, appointed by Governor Newsom in the public member role.
Thank you. Board Member Vicki Granowitz.
Vicki Granowitz, public member appointed by the President of the Senate.
Thank you. And Vice President Neelu Patel.
Good morning, everyone. Patel, appointed by Governor Newsom for the advanced practice role.
Our quorum has been established for today.
President Trujillo, I am also present. It's fine. Board Member Allison Cormack, public member appointed by the Speaker of the Assembly.
My apologies, Allison. I'm sorry.
I'm hiding over here.
And then we just present.
Our board counsel, Reza Pejiesh.
Reza Pejiesh, board legal counsel.
Thank you, Reza. And our executive officer, Loretta Melby.
Thank you. I'm Loretta Melby, or Lori. I'm the board's executive officer appointed by the board, and our board member, Katie Nair, from newly appointed, had another meeting she had to attend this morning, and she plans to join us about 12:30 today.
Thank you, Lori. At this time, we will move to closed session, and we will come back at approximately 9:30 this morning. Thank you.
It is 9:33. Our board president is going to take roll to establish a quorum, and we will begin our day 2 board meeting in open session. Thank you guys for your patience.
Thank you, Lori. So I will take roll call to establish our quorum. My name is Dolores Trujillo. I am present. Vice President Neelu Patel.
Patel, present.
Board Member Jovita Dominguez.
Dominguez, present.
Board Member Patricia Nguyen.
Nguyen, present.
Board Member David Lawler.
Lawler present.
Board Member Vicki Granowitz.
Granowitz, present.
Board Member Allison Cormack.
Cormack, present.
All right, our quorum has been established. We can move on in the agenda. We're at item 4.0.
Good morning, everyone. Welcome to day 2. The report of the This is the report of the Enforcement Investigation Intervention Committee. The first item is an information only, a presentation by the executive officer regarding reviews in which the requirements of direct patient care and work passing narcotics were removed or imposed by the Intervention Evaluation Committee, and a review of the program extension beyond 3 years presentation of the intervention program statistical data. So at this point, I'm going to turn it over to Lori Melby. Thank you, Lori.
Thank you. Thank you for that. So agenda item 4.1 was from a board meeting that occurred last August where the board made a motion to review all of the IEC, that is the Intervention Evaluation Committee recommendations that required the intervention participants to complete direct patient care hours and work with passing narcotics. And so as you can see on page 5 and 6 of your materials, that it does show that information. It shows how many petitioned for successful completion, how many were granted, and how many reviews have been sent to the executive officer. That is a cumulative total. That is 56 that have been sent to me for review. 19 of those I have approved on those recommendations. Some of them have extended longer than the 3 years. Some of them have had to get some work as an RN that did not mean that it needed to be in a direct patient care role. And 31 of them to date have been kicked back to the IECs for a reconsideration of their motion. We are a year out from when that motion was made, and we are still continuing to get those re-reviews. What we're running into now is previously we have 9 IECs. And so if a person was seen in IEC 9 and they made this recommendation, we would get them back to the very next IEC, which could be IEC 3, which is not a committee that they are used to seeing, or the committee is not used to seeing that member. And over the last year, many of the committees have looked at it, made recommendations based on their interpretation of the facts that are presented in front of them. We are now getting pushback from our IEC committees saying if they're not familiar with this intervention participant, they do not want to make a new decision. They want to have that go back to their original IEC. I understand the concept of that, but I have some pushback on that because they're all professionals, they're all RNs, they're all medical doctors, they're all psychologists, et cetera. They're all public members. And we expect consistency from IEC to IEC. What we don't want is someone bouncing from IEC 3 and saying, oh, I only want to be seen by 9 because I know 9 is going to give me this, but IEC 3 won't. And just for a caveat, I'm not picking on IEC 9 or 3. I don't know anything about them. I'm just throwing out just random numbers. So with that, we understand that there's still more education that needs to happen. So previously we've met with legal. We're trying to work around our Bagley-Keene requirements, and the Bagley-Keene requirements that says that in order to present information to a committee, even if it's training, you have to have it publicly noticed and you have to have a quorum. We have 9 committees. We would need 3 members of each of the 9 committees, which would be 27 people to be in one location at one time. Our IECs are not considered advisory to the board because they make decisions as they're appointed by you guys to make those decisions. They become a pseudo board. And so they have to meet in person. So that means we would have to get 27 people, the correct 27 people from each one of the IECs to be present in one location to do this. It has been a scheduling nightmare, and we have not gone forward with that education. So currently we flipped. We've now changed our process, and in our open session for every IEC going forward, we will allot 30 to 45 minutes in the beginning for me to enter into those open sessions and provide the education from our board. The request again that says, direct patient care is not required. Working as an RN may be required, but direct patient care is not required. Passing narcotics is not required, unless you had that caveat that said there's evidence of some kind of patient harm or safety issue that has been provided. The biggest thing that I'm running in is we will have a participant say, I want to go back to work in ER, ICU or whatever, and it's the area where they diverted the medications in. And so our committee is still pretty adamant that they want them to work in direct patient care doing that exact same role. And that's where we have to really kind of have a conversation around it, because prior to their addiction make an effect on them or a mental health issue escalating, they were a safe practicing RN. And so if you're able to manage the addiction and manage the mental health issue, it didn't change the way that you practiced. Your basic RN skills are the same, and you could be a safe practicing nurse. So what the IEC really needs to focus on is how are they doing on recovery, not how are they doing on recovery and are they able to pass narcotics? How are they doing on recovery and are they able to work in a direct patient care role with the same amount of stress? Because in your addiction treatment or mental health treatment, you're learning how to manage that stress. You're learning how to do that. You're learning how to work with triggers, and you have your inner circle, your outer circle, all that kind of stuff that you have to manage those issues, because although, yes, we might have access to narcotics in those situations, and that might have been a trigger before, the IEC needs to be comfortable enough in their recovery to know that they can be safe. Now, we do have sections within our uniform standards that do say they have to work part-time first, and that they can get 2 worksite monitors, positive reports, and then they can go to full-time. That's ultimately what we want them to do. However, it's just work as an RN. It's not so utilizing your license. And our RN license is vast. Our RN license allows me to do my job. Our RN license allows Board President Trujillo to be a NICU nurse. Our RN license over there with Nilu allows her to be a nurse anesthetist, you know, and so on. And Jovita uses her RN license to teach nursing students. So the only 2 here right now that have a specific job requirement to be able to pass narcotics is going to be Nilu and Dolores. Jovita could pass narcotics if she's in a clinical setting with her students, but she's not going to be passing narcotics in a theory classroom if she's teaching. I'm absolutely not going to be passing narcotics. Please don't make me. So with that, I still have to have my license. And so because nursing is vast, we have to have an understanding that these people are licensed to practice nursing, not licensed to do direct patient care. So could they do direct patient care in the future? Absolutely. That is also one of the reasons why we're a part of the substance use disorder survey that's being put on with the NCSBN, because we have successful completion. We have a lot of really good successful completion, and NCSBN was able to quantify that in prior surveys and studies. What we haven't found is what happens to recidivism, what happens if they relapse later. And so now we will get that information, and if we have to shift and adjust at that point, we can, understanding that mental health issues, substance use disorders don't magically disappear. They're there. And if they successfully complete, they are welcome to come back in our program at any point. It's only if they don't successfully complete, they can't go back into that program. So if they successfully complete and they're able to stay sober for 5, 10, 15 years, great, fantastic. And you relapse 15 years out, you're welcome to rejoin our program again at that point and utilize it again. So we're always going to be here to support. The other thing that I really want to make sure we put out to our IEC members is the people that have entered into this program are the people that are doing the right thing. They're choosing this program. They're choosing to be rehabilitated. They're choosing to be tracked and monitored and looked at constantly, sometimes daily check-ins, sometimes, and it's a small percentage that are in here. The majority of the people that are suffering from these issues in the field of nursing are not seeking out this care and are not being monitored in this way. And so we are truly monitoring these people that are doing all the right things, not excessively, but in an amount that is more than the people that are not. And so we need to keep that in mind too when we're looking at successful completion, because our numbers are those that are mandated to do reporting, are mandated to do the drug testing, et cetera, where the other nurses in treatment, we don't have a reporting criteria like that because we will never know that they're in that treatment arena at all. So I hope to see those numbers continue to decrease. I have seen less and less of them come in front based on where we were a year ago, but we are a year out. We're still seeing them. I think there's more education that has to happen.
Thank you very much, Lori. It is nice to see the progress we've made in a year. And I know it's been a lot of hard work, so I really want to thank you for that. I have one quick question, and that's just on program length. In your graph here on page 5, only 14 cases that you've reviewed are longer than 3 years. That was definitely not the impression we had as we were going through this. It seemed like so many people were beyond the 3 years. So, I mean, if you could just comment on your observations on that.
Of the reviews that I've received, so again, a lot of these comments happened before the board made the motion for me to do the reviews. And our staff had jumped in and started working on these well in advance of them coming to me. So there could have been more. I don't know that data.
Okay.
But I do know that as soon as we started receiving complaints the year prior to the motion, so we're about 2 years into this right now, our staff jumped on it immediately. They started looking, they started reviewing, they started pulling data. They started really checking the numbers and the information that was sent to us from the vendor, doing deep dives, going into that and finding where there was inconsistencies, finding where maybe the letter of the law wasn't being followed. And our staff discovered those and rectified those as quickly as possible, even before you guys made the motion for me to start looking. So you really have to take credit where credit is due, and that goes to the staff. That doesn't go to me. So there was a year at minimum of them doing cleanup and finding those outliers and redirecting that and getting them back in front of committee and getting them completed before I even stepped in. So once I was asked to step in and start the deep dive, they were well on the way of correcting it. So by the time I've done it, I do expect to see a lesser amount, because if there is a greater amount, it's already been addressed. So we did have many more completions overall in, I think, the last quarter of calendar year 24.
Okay.
And then the beginning quarter of calendar year 25 than we've seen historically, really just finding those and cleaning those up. So of the 56 that have been sent to me, 14 of them were greater than 3 years. Many of those were just to allow for additional, kind of like we did yesterday. We defer making the decision until we get more information. So they went in front of IEC. IEC said, you know what, I'm missing this kind of evaluation. Get that evaluation, come back in 3 months, and we'll complete you.
Okay.
Or right here towards the end, it looked like you started to slip. I want to give you 3 more months just to make sure that that was just kind of a hump that you're over and that you're actually on track and you're consistent. And then they feel comfortable to complete them. So usually the ones that are over 3 years are not like a year over 3 years, 2 years over 3 years. It's usually 3 months, 6 months, allowing them to wrap up any pending stuff that they need to complete to get everything in order to be successful upon completion. The one thing I do want to point out, though, in our law, it's 3 to 5 years. So us hitting that 3-year mark is fantastic. It's not the expectation that everybody complete at 3 years. We know it's 3 to 5 years. And statistical evidence-based data says it's about an 8-year process for recovery. So us completing our participants in 3 years, 4 years, or 5 years is still completing them from this program, but they're going to continue to work their recovery for a solid 8 years before statistically it shows that at about 8 years in solid recovery, you can kind of take a breath, a little bit of a breath, but you're always going to be vigilant. You're always going to work your steps. You're always going to be on top of that. But us saying you've got a good foundation at 3 years, we're willing to let you go out and kind of try this and do this. You've got a solid foundation, go and practice safely. it is a bit of a gamble. That's always been kind of the thing that we have to balance because we know that evidence says it's a much longer process.
Great. Thanks very much, Lori. I'd love to open it up to any questions or comments from the board. Hearing none, would the board moderator please take us to public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment.
I was hoping if I
Sorry. There we go. I've activated the question and answer feature, Slido. Members of the public can indicate that they would like to make a comment by typing into the question box, I would like to make a comment. Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, I would like to make a comment. Committee Chair Nguyen, there are no public requests for comments on the WebEx Slido. Do we have any in-person requests for comments there in BRN HQ?
No, we do not.
Thank you. Would you like me to close this window?
Yes, please. Thanks very much. So that was information only. Thank you very much, Lori, for that presentation. We'll move on to item 4.2. Again, information only, and it's the Enforcement Division update. This will be presented by Shannon Johnson, Enforcement Division Chief. Good morning, Shannon.
Okay, sorry, get situated. Okay, so I'm Shannon Johnson. I'm the board's Enforcement Division Chief. 4.2 is the Enforcement Division update. So the general information is just the ongoing, as Lori mentioned earlier, the NCSBN 5-year pilot study, which we're continuing on. In May 29th, 2025, board meeting, you voted to allow the oral fluid testing as an acceptable method of random drug testing for probationers and intervention. And I just want you to know that we are in the process right now of getting that addendum to that contract. So we are working on that, and hopefully that will be completed soon. We also continue to recruit all of our expert practice consultants, and that information is here as well. The complaint intake unit is continuing to utilize the new CPRG, which are the complaint prioritization and referral guidelines to triage cases in collaboration with DFI BRN. We do have standing meetings where we do triage meetings together, all of us, so we can discuss the cases and get them moved along. Discipline unit. So as of July 29th, 16% of our cases have been pending at the AG's office. You will notice that that number has gone up over, I think in the beginning of COVID, we were at like 4%. So it has increased. As of 2025, the citation desk has been moved. It was residing under the intervention manager. She was overseeing intervention, legal desk, and citations. Historically, previously, citations was part of our discipline unit, and it makes more sense. They deal those non-formal citations, so we have moved it back, and that's what occurred just this last April. The probation unit is currently working on the enhancements to the website, so we do have completed the video. We have the FAQs completed. We're waiting for that final approval, and we will be posting those. So we are in that final stage, and I know Allison's happy about that. Currently, there's about 48 cases on average per monitor. in the probation unit, which is a really good number. Very comfortable with that. And then following tables A through, gosh, I think D, E, F. Oh, gee, sorry, a lot of tables now. Are all the statistical information that have been provided with stats. I know there was a comment made that it looks like our, if you look at our total number, which is now for our last fiscal year ending 24-25, was up to 740 days to complete, when a few years prior we were at 529. So I just want to explain a little bit. So in 24-25, those numbers reflect all the cases that closed. So we have to look at the age of that case. And so what I did is I opened up 18 months worth of data prior to that fiscal year period of time to see if there were any spikes and anything going on to figure out why that increase occurred. And there's a few things that happened. In fact, I was just before this meeting, just re-looking at it again to make sure. So we had lost our discipline manager. So we were down a discipline manager. We were down a discipline analyst. At the same time, so when that analyst left, we have to move the cases over and refer them over to other analysts so they can continue processing. So that just increased their caseload a little bit. For a period of time. We also, our fast track cases, which I don't know if you're familiar with, that's all of our, we consider paper cases. It's our Corey cases and all of our out-of-state disciplines. Normally those are moved pretty expeditiously. We really had a slowdown in that caseload for a while. We've saw that that has been corrected. And so now moving forward, that'll be fixed. We also had an increase in about a 3 or 4 month period of time with our in-house investigations time. So that time does add then to that overall time. We also had an increase on the DFI side. So it wasn't just ours. I think it was investigations across the board. So there were quite a few things happening. I can't really pinpoint one thing specifically. It was a few different areas, but we do watch that. Those numbers are very important to me. So if there's, information that you would like to see or you have questions, I'm more than happy to try and answer it. I may have to go back and dig and do some more research, but I do have the data if there's something you want to know. So that's all I have for 4.2.
Thank you so much, Shannon. That is very helpful. I was going to ask you about that. I appreciate you being proactive about it. I have one quick question and I'll open it up to other board members. The oral fluid testing, thanks for jumping right on that. Could you give us just an idea of how that will work? We've heard nurses during public comment saying, I want to go visit my sick parent,
right.
I can't because I have to test. So how would a nurse like that petition for this opportunity?
Right. And as during the presentation at the last board meeting, as Sean was stating, it's really to be used as an alternative in maybe emergency type situations or where another testing type is not available. So if there's a situation that occurs that they can't get to a testing site and we need them to test, they can contact Vault. They need to make sure that they have the oral fluid kits. And if they do, then they can do an oral fluid test. And then if we needed to, we could always follow up with a different type of test later just to ensure and cover those gaps possibly. So it's going to be a coordination effort of getting the kits, making sure they have them. If they don't have a kit, they're not going to be able to do the fluid testing. So, if they're in a rural area, we may be able to supplement testing once in a while. It's not a test type that you want to use exclusively, as they stated before.
Thank you very much. Any other questions or comments from board members? Go ahead.
Thank you, Shannon, for the information. I have a question that's maybe a little bit outside of what you're presenting, but also concern to me, being a clinical provider out in, the field. I'm being asked often what to do about providers that are diverting, but then are undergoing the investigation process. And of course, there's due process that takes time to go through these things, but they're still in the clinical area. And we know that they're diverting. What can a clinical, like an ambulatory surgery center or a clinical site do to prevent this person from contacting patients?
So As the employer, you have some options. Of course, there's no mandatory reporting in California for RNs, but one, reporting it to the board, and of course, our investigation takes time. The employer, you could do administrative leave of absence while you're doing your investigation. You could contact your local police department if it includes diverting, which is theft of controlled substances, which could be felony charges. So there are things that an employer can do in the meantime if they want to remove that person from having any effect on. But for administratively for the board, at that point, it's an allegation. We cannot remove them from work until we have enough proof to either file and obtain an interim suspension order through the administrative court or file the pleading to pursue that disciplinary action. And even at that point, the accusation, we cannot remove them from work. That is simply just a public notification that there has been causes for discipline that have occurred. And then once we have that final disciplinary outcome, then whatever that outcome is, we take that into effect.
Okay, thank you. And that's for the public. So I definitely wanted to make that, information out there. Unfortunately, a lot of these, small clinics and things like that don't want to intervene because they don't want to get involved. So that becomes a problem because then this person then goes out to another clinic and there's no information about this person being,
We do
a risk.
see that. We see facilities, I'll just give an example. I'm not picking on travel nursing, but travel nursing, they'll just cancel their contract, send them on their way, and they'll just go to the next hospital. And risk management, it's touchy. And so sometimes they don't want to report that there's been a major diverting issue.
Any other comments or questions from board?
I just wanted to make a statement. Licensing gives the person the ability to practice, and licensing, if revoked or suspended, removes the ability to practice. But we are not the employers. And so the employer, which allows the person to have contact with the patient, has to have a responsibility in this. And when we grant a license to anybody, we are not the ones that say that this person is competent in their skills. That's actually a requirement the employer has to do, is they have to onboard them. They have to make sure that they're competent, and they are responsible for protecting the patients that they serve and the public that they serve. It is a partnership. So although, yes, in California, we do not have a law that says employers must report all license activity that violates the Nurse Practice Act to the board. Board of Vocational Nursing does. They have that requirement. So if you're an LVN and you do something that is not in alignment with the law, they must report. That is not our law. And because of that, we do not get many of the reports that we would like to get. So there's many times where we receive a case where we're looking at or investigating and it says, we noticed it on this date, and this is what we did. We did disciplinary action at the employer. And then on this date, we did another disciplinary action at the employer. And then on this date, we did another disciplinary action at the employer. So that employer has gone through their progressive discipline for 6 months to a year. We don't even know that it occurred because it hasn't been turned into us. And so there is no law to turn that in, which is why we're always saying there's not a law, but please do it. One of the examples that Shannon did bring up is with the travel nurse contract. So I just want to make sure that it's not a travel nurse specific that we're talking about. It's the way that the contracts are made with the employer. So when you go in and you make contract with the company, the travel nurse company, that employer reserves the right to cancel a contract for any reason that's outlined in that contract. And so if there is issues with accountability, with dependability, with scheduling, with personality issues, not just potentially diverting or a patient care error, they can cancel that contract at any point. And then that person, we don't get a copy that says we canceled contract with so-and-so and it gets reported to our board. It just gets reported to that travel agency. That travel agency can either retain that nurse and place them at another site, or they can cancel that nurse from their employment and they can go get employment elsewhere at another travel agency even, or another healthcare organization. Again, it's based on that employer. So a lot of people want to think that the board has the ultimate control. And we don't. We issue a license, we remove a license. When you're out there working, it is up to the employer and you as the RN employee to work collaboratively to make sure that you're following all rules and regulations, to make sure that you're practicing in a manner that is ethical, and that if you are doing something like diverting medications or such, that typically is managed at an employment level first. I did kind of a push with some of the hospital associations that I met with about, if they are stealing fentanyl and taking it, that is theft, you can pursue criminal charges. That was not necessarily favorable pathway for many of the people that I talked to because of the risk management issue with that. So it is there. We're going to let you know that option is there, but you also want to work with our nurses, and that's why we have that intervention program that says we're not going to be disciplinary on you. We want you to get healthy. We want you to be rehabilitated. So we don't want to take action and be disciplinary all the time. We want to help you get better. And the hospitals and the healthcare organizations kind of take that same stance, is you don't always want to go criminal, right? You want to help them with a employee contract of some sort that says, this is what I expect you to do to meet these guidelines. Let us help you. Because you don't want a nurse that is afraid to practice and make a mistake, because we are all humans.
Thank you. That's an excellent point of clarification, because I think the public does assume that the board has ultimate authority just to police every single nurse out there.
Yep. Partnership.
Thank you very much. Any other board comments or questions? Hearing none, would the board moderator please take us to public comment?
We will be opening for public comment now. Slido. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Slido. Members of the public can indicate that they would like to make a comment by typing into the question box, I would like to make a comment. Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, I would like to make a comment. Committee Chair Nguyen, there are no public requests for comments on the WebEx. Slido, do we have any in-person requests for public comments there in BRNHQ?
No, we do not have any. Would you please close the public comment window?
Thank you.
Thank you. Okay, so that, again, information only. So we'll move on to agenda item 4.3. Again, this is an information only item, Investigations Division update. And Shannon will be presenting.
I believe
Actually,
Yvonne may
Yvonne.
be online too.
Yeah, so
And
I believe Yvonne has been elevated. Let me make sure she has. Okay. Yvonne, are you able to? Okay, thank you. We see you, and just want to make sure we can hear you.
Yes, good morning. Can you hear me?
Perfect.
Okay.
Yvonne, yes, thank you.
Good morning, and again, thank you, Chair Nguyen. I apologize for my inability to be there in person. I am the Assistant Executive Officer, Yvonne Leonard Taps, giving the presentation for our investigation section, our investigation division. Under general information, we continue to work with the Office of Organizational Improvement to map out our workflows and to identify any areas of efficiencies. The OIO team continues to work with our subject matter experts from the different levels and different units and we will continue to report on this project at future meetings. But it is still a work in process. Under investigations, we are still, on June 10th, we launched the Enhanced Triage and Preliminary Case Work Pilot. And what that is we have a staff member who is not a special investigator, who is collecting data, gathering information on cases before they are assigned to an investigator to help with the investigation, being able to start the investigation immediately upon assignment. That is an associate government program analyst position. She is an individual that has a lot of experience with our investigation, and as of right now, that pilot is going very well. As you may recall from prior meetings and the CSA audit, our special investigators are limited to only having 30 cases assigned to them at any given time. This AGPA, she is allowed to have more than that because she's submitting requests for information, documentation, and there's downtime in between each of those requests. We will continue to report on the progress of that. We anticipate this pilot being at least a 6-month pilot. And then we will work, if we want to implement any of the findings, we will work with the internal audit office of Department of Consumer Affairs to implement any of those changes. As I'd mentioned, that our special investigators do have that cap. Currently, all of our full-time special investigators have an average of 29 active cases. Because of that high caseload, our supervising special investigator 1s, there's 3 of them, and our supervising special investigator 2, Deputy Chief Nicole Bowles, are actively working cases. The investigation, we continue to meet on a regular basis and exploring multiple options to address this high caseload. That concludes the report. Is there any questions from the committee?
Are there any questions from board members on this item? Well, I have just one quick question, Yvonne. Thank you very much for that report. So for the last several board meetings, this last paragraph on page 23, which describes what you just talked about, how you're going further up the chain of command to actively work these cases. And you said we're exploring, multiple options, but this is the option that keeps coming up is, that supervisors are taking on these cases. What are some of the other, options or solutions to this really high caseload?
We're also looking to see if there's any limited term positions that we can secure to help with that. I have taken on some of the caseload, providing support for our SSIs 1 and 2, so they can actively work the cases. We have tried in the past to redirect current personnel within the board to investigations. However, that has not been effective. It hurts the area that we're taking the resources from, and the training slows the process down. We work very closely with the enforcement to see if there's any additional triage they can do before it is assigned to investigations, and that has been extremely helpful. But right now, those are our only options. We're also looking at, is there any other efficiencies that we can identify in our current work process as we're working through the mapping with the Office of OIO. So we're trying to address this on all different angles, but we are limited. We do have limited term help currently with us at this time. We're using full-time limited term SIs, and we're also have a retired annuitant that works. They're limited to 960 hours in a year.
Thank you very much. I just know how busy you are, Yvonne. I know how much work you do for the BRN, and I worry about you actually becoming an active investigator on top of everything else. So,
I'm not actually doing the investigations. If I can provide any assistance in collecting data, if I can provide any assistance entering in data into the BREEZE system, just anything to support our special investigators, our supervising special investigators, and our deputy chief of investigations.
Thank you for that clarification. Lori, was there something you wanted to add here?
Yeah, one of the other things that Yvonne helps us with is subpoena enforcement. We have the ability to issue subpoenas and request information. There are times when that is not responded to, and there's a lengthy delay. And so Yvonne helps with subpoena enforcement. Our legal counsel, Reza, helps with subpoena enforcement as well. And at times, we even bring in the AG's office to help us with subpoena enforcement. When we are asking for materials to be able to complete an investigation, it's imperative to have a timely response. Many times we don't get that timely response. And so we spend a lot of time just kind of wrapped up in trying to get information to do the investigation, to be able to move it through. We are also exploring, possible positions and what we can do to seek out additional positions to help. If you just look at clear numbers, we don't have enough staff to work the amount of cases that we have.
Thank you very much. I think at this point, we'll open it up for public comment. Board moderator, would you please do that for us?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Slido. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will now give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Committee Chair Nguyen, there are no public requests for comments on the WebEx Slido. Do we have any in-person representation requests for comments there in BRNHQ?
We do not. Thank you very much. Would you please close this window?
Thank you.
Thank you. Okay, so we'll go ahead and move to item 4.4. Again, an information-only item, and it's an update of the intervention program, and Shannon Johnson will be presenting. Thanks, Shannon.
Yes. Again, Shannon Johnson, I'm the board's enforcement division chief. Agenda item 4.4 is the intervention program updates. And so the management team, as Lori had said previously, some of this information is a little redundant, but we still continue to attend all of the IEC meetings and identify gaps, regulation, assist with that transition with the vendor as well during those meetings. At the February 28th, 29th, 2024 board meeting, you voted to allow us to begin drafting regulatory language. With the transition, that's kind of been delayed a little bit. We still have every intention on getting in there and starting to update or put together a package for you to review for updates. The contract, we're still in that transition phase with the new vendor, Premier Health Group. And so we're continuing to work on that transition with them, getting into the new portal that's being created for all of the stakeholders and all of that. We continue to recruit IEC members. We currently have 5 vacancies, I believe. And board member Nguyen and board member Patel did interviews last week for some of those positions. And hopefully we will have some more to interview prior to the next board meeting where we will bring their recommendations to you for approval and appointment. Let's see. Lori, again, she's going to be attending those IEC meetings too. So starting on the August 26th schedule, IEC 3, I believe, is where she will start that. So by the end of the year, we'll have hit almost every IEC, hopefully every member. Sometimes we don't have quorum, so we may have some that don't have not benefited from Lori's presentation for them. There is some data attached to this AIS. I just want to point out a couple things on this. We had the highest amount of closures ever in intervention in fiscal year 24-25. We also had one of the lowest numbers of not successful completions. So that means the majority have successfully completed, or more so than in the previous fiscal years. So I just wanted to point that out. I do also want to point out there's an intake and then there's an accepted. And I just want to explain that. So the intake is the intake interview that is done with the vendor and the applicant, a potential participant. The accepted is when the IEC formally accepts them. So you'll see intake number is going to be higher because some of those after intake decide maybe they don't want to enter the program. So unless there's any questions, that's all I have for the.
Well, I have just one quick question. So the complaints we heard about Maximus, that caseworkers weren't necessarily responsive, or, there was kind of miscommunication or really poor communication. I'm wondering with this new vendor, how you feel like it's going. And I know it's new and it's only been, 8 months, but.
I am hearing that they, especially in the IEC meetings, they have mentioned that they like their clinical case managers, that they do see a difference in the communication. And so I'm very comfortable with the clinical case managers with Premier. I think they're doing a really good job. With where they're at right now. We're still in transition. We still have a lot of open ends still to smooth out. But other than that, I think they're doing a great job with where they're at. And we're just trying to assist them to, get to where I think we're all comfortable kind of taking a step back and allowing them to just do it on their own. Yeah.
Great. Good. Thanks very much. Any questions? Yeah, please go ahead, Board Member Cormack.
Thank you, Chair Wynn. I just wanted to follow up on that, Ms. Johnson, because we heard a number of comments earlier this year. I mean, completely understandable that they are on their third, I think someone was on their fifth case manager. So is it your sense that initial instability has, diminished around, people having their clinical case manager assigned and or change?
This is a really different position. I'll be honest. I think when you think about a clinical case manager for a participant going through a treatment program, you really don't think that it's to the level of monitoring that it is. It's really close to what our probation monitors do. And so you really have to monitor every aspect, and it's more of an administrative monitoring than it really is on the clinical side, even though they do have clinical knowledge and, some insight to that. So I think coming into it, maybe for some, the job isn't exactly what they thought it would be. So there's turnover, and I think with any job, especially new, you're coming in, you don't know what you're walking into. There's going to be some unknown once you realize where you're at and what the job entails. For some, it's not for them. I think the clinical case managers they have right now are working out very well. I hope that they're happy where they are. I'd like to see them stay, and the monitors that work with them, 2 very good monitors. So we'll see. I haven't seen any turnover since, but it was in the very early days when we did. And then they just had another that got moved to a different unit, but that was, she had left on, medical leave for a minute. And so somebody else stepped into that position.
Okay. Thanks for that update.
Any other questions or comments from board? Oh, sorry, go ahead. Board Member Granowitz.
I know that I received a couple of letters, I'm assuming we all did, talking about the nursing groups and the leadership of them. I didn't exactly understand what the complaint was. Anyways, I didn't know if you had any feedback for us on that.
So as part of the intervention program, they are required to do some meetings with a nursing support group facilitator. The intention behind that is to give nurses a safe space to be able to kind of talk about the issues within healthcare and their issues with their substance use or mental health issues. And we have historically shared out information on who we have and who are available. Sorry, I don't want to say who we have because we do not employ them. Who is available throughout the state that provides this service. During the board meetings and the committee meetings in the last year or two, we have heard many issues arise from the nursing support group facilitator side. We've on both intervention participant as well as the nursing support group facilitator. Some of the facilitators have said they don't have appropriate access. They don't really know what's going on. They're not getting a lot of feedback, and that they may not agree with some of the items that have been addressed by our board moving forward to align better with our regulations and statutes. They showed up in public comment. They provided a lot of feedback. Additionally, on the other side of that, we have intervention participants who are not satisfied with their nursing support group facilitation. They're not available. They require them, some to be in person, some move their clients from one, like we had a person that retired, and so they just assigned their cases to a different support group without input from the intervention participants of where they may want to go. So there are some issues that have been identified in that realm that we are looking at solutions of addressing. So we were at a NCSBN conference as a enforcement investigations kind of team. I went as well as our assistant executive officer with the National Council of State Boards of Nursing. There was a presentation by Birchwood Solutions there that when we heard it, felt like it hit every single box that we could even imagine. It was an amazing presentation, and we were like, heck yes, we want that. We're not able to obviously just check a box and say we want that and start that. That's not in line with the state process. So at that point, we brought that information to you guys last board meeting, that there is providers out there that could oversee this nursing support group facilitation in a manner that could be helpful for our board staff as well as our board. We presented that information. What was asked to us to bring that to committee for additional discussion. So at the next EIIC, Birchwood will be asked to come back to present what they have available to offer. It does not mean we're going into contract with them. It means we are starting to explore different companies that are out there that have different things that we didn't even know that existed, right? We didn't know that these services were out there that could help us in a manner that they could. If that is something that is decided on by our committee to make a recommendation to pursue contracts with companies that may be able to help support our nursing support group facilitators, that will be a recommendation to the board. It will come to the board will vote and see whether or not we want to explore contract. Very similar way that we did when we identified we had an issue with our fingerprint processing for out of state, that it was causing this really kind of lull and a bog down. And you guys, we came to you, we asked you, said, yes, let's look at exploring contract on fingerprints. And so now we're in a fingerprinting contracting state process. And so if the board, after presentation by Birchwood, says this is something that we are interested, let's go out and see what we can do to contract with a company that can provide these services, then we will go through that contracting process. We will go out to bid. We will follow that. That is not where we're at right now. Right now, we're just exploring opportunities and options that are out there to help us better manage this section that was brought to us as a complaint, both by the support group facilitator and a complaint by the intervention participants, saying that this part needs looked at better. It was misunderstood by at least one individual that we did receive the email on, that believed that we were choosing Birchwood and we were moving with them and that they were going to be forced to do that. That is not where we're at. That is not the process that happens within the state. And one of the things that we liked about Birchwood was that they would contract with our nursing support group facilitators that are currently established in California, bring them on, provide them training, and align them. So it wasn't that if we chose to do a contract with any of those companies that could provide that we were trying to push out any of our nursing support group facilitators that are currently working throughout California. What we do have to understand with our nursing support group facilitators is some of them do this as a service and they charge $0, and it's free for any participant that is able to utilize that group. Some of these charge monthly for this by participant for this to occur, because so it becomes a business at that point. And so we have asked for fees alignment to be transparent, to post it on our website. We have worked with our new vendor on providing options for nursing support group facilitation. Previously, and correct me if I'm wrong on this, Shannon, previously the prior vendor would assign to groups. And we don't employ these, we can't assign them to them. So we kind of look to make sure they're evenly dispersed. It used to, when they were all in person, be kind of geographically laid out, but now we're hearing that most of ours are not in person. So really you can facilitate a larger kind of population at that point. So we're working with a system that needs improvement. We're working with a system that needs oversight, and we're trying to find solutions for that. And we do understand that there are people in that system that this is a business for them. It does bring in revenue for them. It may even be their entire work. And if there is a perceived threat to that, that is taken into consideration. And this person, my understanding by reading that letter was they took it as a threat to their business that they and the service that they provide, and there was concern around that, so they reached out to the board members for that. I've not responded at this point. I do plan to respond. I'm pretty sure, this is public, so if they're on and watching, we might get some public comment on this. But this is being stated here. I'll do a very similar response when I do write back.
Yes, please.
Yes.
Do you have any thoughts on how you deal with the discrepancy between some of the groups being free and some of them being charged?
That was one of the reasons why we were looking at Birchwood, is when we found out there were companies out there that contract with a facilitator and set a standard fee. And we were looking at, potentially, and this could be in our next agenda item when we're talking about sunset, we were looking at how we can, as a board, help to offset some of the administrative cost. And that would be a legislative process. So there are many pathways we're looking at on how we can work with that or assist with that, but there's not anything clear because these facilitators are not associated with the California Board of Registered Nursing in any way. We do not employ them, we do not pay them, and we no longer assign to them. We provide information to our participants, and our vendors says these are the ones that we are aware of that are available. This is the information. Some of them have given us their fee schedule, others refuse to give us their fee schedule and say that it's illegal for us to have it. And that's not an accurate statement either.
No, I guess my concern is I used to run therapy groups and sort of support groups for sexual assault survivors. And therapy groups, you would charge what the going rate was, but the support groups, the therapist isn't doing as much work as the participants. So they were either free or a nominal charge for it. And you do it as public service in your practice.
Many times this is, but I do want to make a clarification, and Shannon, I will.
Is it therapy?
It's not therapy, and it's not a therapist that runs our nursing support group.
No, you wouldn't need them because it's not therapy.
Correct. So there are some requirements for them to have specific requirements that I'm not remembering. So I
The
can't quote
criteria
off the
is
top
in
of my
uniform
head.
standards to be a nurse support group facilitator. So there is no mention of fees or cost or what they must charge, but there is many inconsistencies from one nurse support group to another. They all, at this point, are online. None are in person right now, currently. And yes, we do give them a list now. They have an option to choose which nurse support group they would like to go to. But other than signing an agreement when they become a nurse support group facilitator, that's the only agreement that we have between that facilitator and the board. And it states also that they must not turn anyone away for cost. So if you're the one of the facilitators charging the highest amount and you have someone who can't pay that, they're supposed to take them into group anyway. And I believe Birchwood also stated the same, that cost, and they also have something in place for people who cannot pay that for at least the first few months to help accommodate the fees for nurse support group. Another thing I want to mention too is currently those funds are changing hands between the facilitator and the participant. And so to have a little bit more consistency where the participant's paying through a more formal method of payment to like an employer paying us, and then it be accounted for. I'm not sure where those funds are being shown at or if they're being accounted for. And then the payment is from the employer, which would be Birchwood, to the facilitator at that point. So everything all the way around would be accounted for, whether it be Birchwood or anybody else. But that's really what we're looking for, is some accountability, consistency for our nurses.
Thank you. That's what I'm looking for.
Yeah, thank you.
During the crisis in our intervention program, one of the things that really kind of kept me awake at night a little bit was the nursing support group, like how little information we knew about them, and yet we were requiring. And I think probation participants also have to go to nursing support group, and we're sending them there. We don't really know how it works. We don't really know what the fee schedule is. It's one more thing. So I'm glad we're looking to try to rationalize the process. I don't know if it's an independent contract. My mind is wide open on it, but I do think it is something we have to tackle. And I really want to tell staff how much I appreciate you kind of digging into this.
And I do want to say it's twice as many probationers attending nurse support group than it is intervention.
Okay, thank you. Any other questions or comments from board members before we go to public comment? Okay, board moderator, would you please take us to public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Stephanie would like to make a comment. 1 second, please.
Good morning.
Good morning.
My name is Stephanie Trum, as alluded before, registered nurse, a certified addictions RN, licensed advanced practice, alcohol and drug counselor. I'm a former case manager with Maximus, former committee member of the intervention program. I do have a few comments. Number one, the board already has a contracted vendor, and if someone's absent in the intervention program, if they were absent from nurse support group on both sides of the fence by Uniform Standard 5, they have to report it the next day within 24 hours. That's already taken care of. All the groups are already virtual. The nurse support group leaders already send the monthly reports. And the nurse support group is designed to be an emotionally safe place for RNs to gather, address their feelings, concerns, receive support for the recovery, access available resources, including jobs, discuss how to interview, etc. It's not designed to be a formal class. It's not designed to be a business. And I have a concern about that. I don't think people need to have a master's level to be an effective nurse support group leader. Uniform Standard 5 does not delineate that. And so those are my comments. I think the essence of the safety of nurse support group may be lost or diminished significantly. if you have yet another vendor come in, you already have a vendor who could address some of these, and perhaps the board could come up with universal guidelines that they want each nurse support group leader to sign. That would be helpful for some more additional accountability and conformity. Those are my comments.
Thank you for your comment. Sorry, I'm trying to see my there we go. It came back. Okay. Sorry, Committee Chair Nguyen, there are no other public requests for comments on the Slido. Do we have any in-person requests for comments there in VRNHQ?
No, we do not. Thank you very much. You can go ahead and close this window.
Thank you.
Thank you. So that concludes the business of the Enforcement Committee. I'm going to turn it back over to our chair. Is this an appropriate time to take a quick break or?
Yeah, at this time, we'll take a 15-minute break. It is now 10:40. We will come back at 10:55, or actually make it 11 o'clock. Thank you. Welcome back, everybody. We will again take roll call to establish that we have a quorum to continue the meeting. Dolores Trujillo, President. Present. Vice President Neelu Patel.
Patel present.
Board Member Jovita Dominguez.
Dominguez present.
Board Member Patricia Nguyen.
Nguyen present.
Board Member David Lawler.
Lawler present.
Board Member Vicki Granowitz.
Granowitz present.
And Board Member Allison Cormack.
Cormack present.
Our quorum has been established. We will continue on to item 5.0. This is the report on legislation. 5.1 is discussion and possible action. This is the legislative update, overview of the 2026 BRN sunset review process and legislative requests.
Thank you for that. So we've been getting a lot of requests from stakeholders to really discuss what the sunset process is and why we have it. There is a agenda item in each one of our advisory committees as well. So we will be talking about, APRN advisory committees, talking about various sunset issues. We also held the Nursing Education Workforce Advisory Committee stakeholders meeting in June, where we talked about historic sunset issues as well. And so with that, just to really kind of provide a overview here, we have a single document that provides links to previous sunset reports, previous sunset responses. So if you guys did have a moment, you could go in there and look at some of the same items that were brought up in 2010 or some of the same items that we're continuing to address today in 2025. It doesn't mean that we're not addressing them. It just means that it pops up the same issue in different ways as we kind of manage through that. So, different from private sector companies, being part of the California Board of Registered Nursing, and what I'm talking about with this one is the 9-member board. That 9-member board is established in statute. And all of you up here are able to be here because the legislator was able to get a bill through that said we want to keep this 9-member board continuing to work for this amount of years. Our last one was a 4-year. And so you guys have the ability to continue in your role until January 1, 2027. The legislative session starts the year before, so that is why January 2026, when they're looking at bill deadlines, you want to see a author pick up our Business Professions Code that says our board members can continue in their role. They typically don't put a year on that when it's going to sunset. They leave that blank, and so after we go through various hearings, various conversation with stakeholders, and then ultimately towards the end when it goes for signing, they let us know if we can do this for 1 year, 2 years, 3 years, 4 years, or whether we can't do it at all. If the bill is not submitted If it is not extended, then January 1, 2027, the 9-member board here will cease to exist. I am appointed by the 9-member board, therefore I then cease to exist as well. With that, one of the misconceptions that we get commonly from the public is who will do licensing. Our 9-member board does not do licensing. So the Board of Registered Nursing, absent the 9-member board, continues to go on as a state aid entity. They are underneath the Department of Consumer Affairs. What would probably do is instead of being a board, it would mold into a bureau. And you would then go into that kind of a setting. But enforcements would still continue, investigations would still continue, licensing would still continue, but our 9-member board would not. With this process, the legislative process, what you also have to do is kind of say what we've done for the last 4 years, right? What are some of the accomplishments the BRN has done for the last 4 years? If the legislators had requests for us to do, did we meet them? I can tell you affirmatively, no, we haven't met every single one, and that's okay. I've always been transparent with that. We had a couple papers that were reports that were turned into the legislators in 2029 as well as 2020 on our continuing education provider approval process. And as we shared with our positions and looking at a reorg, we have not implemented that. It is still always nagging in the back of my head saying, I haven't done this, I haven't done this. And I meet constantly with Macaulay on this because she oversees that area. And we were always working on moving that forward, but it is a big project and hoping to see some movement by the end of this year. So with that, we know that we have items that stakeholders have brought forward that need to be addressed. We know that our board members might have items that we want to bring forward to be addressed. With this process, we are given a outline of a report that the legislator wants from us. Within that outline, they ask standard questions to all boards and bureaus, because the Bureau of Private Post-Secondary Education is going through sunset this year as well, right alongside with us. We have an MOU with them. We co-regulate our nursing programs with the Bureau of Private Post-Secondary Education. They oversee the institution and the degree granting section. We only look at the nursing program within that institution. So we don't get involved in financial aid and any of the admission requirements and all that kind of stuff. That is managed through Bureau of Private Post-Secondary Education. We only look at the nursing program and whether or not they prepare nurses and they meet our licensing standards. So with that, once we answer all those questions, we'll be bringing that report to you guys. And so Macaulay is not looking forward to this endeavor, but her, Yvonne, and myself typically start burning the oil at both ends and just really working on weekends and nights and all this other kind of stuff to get this report written. We have backed out our deadline, so we have about 2 months, I think. We're sitting at 6-8 weeks to prepare this report for you guys. We do plan to have it on the Nurse Practice Committee, where the board members, so 3 of the board members will see it for the first time. It will be a public document at that point. It's a draft document. And so we are hoping to get a lot of the kind of nitty-gritty in the weeds editing done during that committee. Once we get through that committee, we'll make those changes and have it prepared for the full board in November. Our plan is to get board approval in November. If we do not get board approval in November, we will be holding a special board meeting in December, where we will again reconvene and ask our board to approve the report. When the report is approved, it will be turned over to the legislative staff in January. So that they can go ahead and start that review. They do a report back to us on what items they've heard from stakeholders. They've been meeting with stakeholders this last year. We've started receiving letters from stakeholders. Again, we've had 2 letters presented to our Nursing Education Workforce Advisory Committee talking about historical issues that have been brought forth in Sunset previously. There's another letter that was sent to the Nursing Education Workforce Advisory Committee that is being agendized for their next meeting, where we will have more discussion again on those very commonly common issues that come forward in Sunset. We do see typical issues that come forward in Sunset are usually around our school approval process. That seems to be a very big section that has a lot of focus. And that becomes a large part of it. Our last Sunset bill, I believe, was about 26 pages in length. A lot of that on nursing education. This is also the venue where we have asked for fee changes. So I shared in yesterday's report, this is where we asked to drop all the fee floors so that I have the ability to drop fees. This is also where the board asked for combining of applications, where we combine the nurse practitioner initial application, the nurse midwife and the nurse midwife furnishing initial application. What we missed on that one was addressing the renewal application. Those are still separate. So we will be bringing forth just some cleanup stuff like that, where we will ask to combine the renewal application. It doesn't make sense to have a combo initial and not a combo renewal. So that was a miss on our part. So this is an opportunity for us to make those changes, bring our suggestions to the legislator at the same time that stakeholders meet with the legislators to bring their suggestions forward. So again, I will reiterate what I shared yesterday. Please, board members, if you have a moment, review the NEWAC materials from the last meeting in June. Also, if you get a chance, watch that one. You can watch it on two times speed if you need to. So that is an option. There is also a transcript. It's not as accurate. So just be aware of that if you do we are given the opportunity to present any issues that we have discovered or suggest any issues to be addressed through the legislative process. And so we want to ask our board, as we're going into and preparing for this, as well as any public out there that wants to have comment, if they have any specific items that they would like us to consider. Again, not something that we can guarantee that we will do, but to consider to bring forward, to put forward in our Sunset ask for next year. So at this point, I'll open it up to the board members here if they have any questions, comments, concerns, etc.
Thank you, Lori. That was a very comprehensive report. I just have one question, and that is if any of the stakeholders or public would like to submit questions or ideas for the Sunset Review for us to consider, who would they contact?
So typically, stakeholders go directly to the legislative staff. They don't typically reach out to us, but I would love it if they started to reach out to us first, because then sometimes we can work on it outside of a legislative process. So an email to me is absolutely acceptable. You guys can, again, public can reach out to all of our board members as well. You guys are all available. But to streamline processes, typically I am the contact point. And so if they have any suggestions, I would love to receive them and take them into consideration. Again, I need to stress, I will receive them and take them into consideration. I can't guarantee that once you send it to me, I'm like, yep, that's going on Sunset. That's going on Sunset, because there are times we receive requests that are not within our jurisdiction. And if we were to ask for that to be added and within our jurisdiction, it would cause a duplication within the government here, right? So what we don't want is they say, you know, the healthcare facilities must report to the BRN such and such. No, that goes through CDPH and HCI. That's not ours. Although it'd be awesome, it doesn't belong with us. So those are the things, like if they have a suggestion that I can take forward, it will. However, there's also some times where they're like, hey, the board should join the compact. Okay, I hear you on that. That's not a sunset issue. That is a much, much larger process and has to be done through a separate legislative bill and not part of our sunset process. So even though we hear you on that, we absolutely understand that that's probably not a sunset process. We would keep that in our back pocket, and that would be something that would be moved forward to a different process. Additionally, we do get a lot of stakeholder comments that ask for removal of some of our authorities, where prime example that you guys will hear frequently is that they don't want us overseeing our academic institutions. They believe, again, it's duplicative. They think BPPE could do that, as well as the California chancellors, both for CSUs and community colleges. That's not what the evidence shows. So again, I might get a suggestion to add that to legislation, but then I will look at what the evidence does and what our board asks, and that may not go forward. So just setting that up, that please put your suggestions forward, but understand that they may not all be taken.
Thank you, Lori. Any question? Board Member Vicki Granowitz?
I don't exactly have questions, but I have my list. So I'm just going to go.
Fantastic.
I'm just going to go through them, and they can be changed, or you can tell me to pack sand. I'm fine.
I will not tell you to pack sand because technically you're my boss.
Okay. The first one is mostly just to get it on the record. I believe it's already in process, which is to consider subsidizing the RN support groups. Coming out of the discussion we just had with Shannon and the inconsistencies in the pay. I know that there's some work already going on, but I just wanted to make sure that was on the record as something I think we should consider.
Yeah, throughout the process, we did learn that there are other states that have legislatively taken that on and have taken a kind of a collection either through the renewal fees or such that would then designate that to be able to help. So that is something that we can put on and explore and see what we can do.
And I'm going to try to get through the next three, and then you can comment if that's okay, because I'm a little reading my writing and trying to get them out in a way people understand is always challenging.
Can do.
But let me just preface my request in that after having been on this board for a number of years and going what we've gone through for the last year, a number of issues have come up for me. One of them is that there is disparity in the disciplinary actions between RNs and MDs as they pertain to DUIs, and I've never really understood that. So I'm wondering if there's a way that the discipline for RNs could be somehow made consistent with what happens for MDs. And in order to actually do that, I think there would have to be some kind of analysis, if that's possible, between MDs versus RNs related to DUIs. And if I don't even know if this is possible, because from what I understand about MDs, there's not a lot's done. So it would be hard to look at recidivism rates in terms of providing the kinds of services that we make our RNs go through, that MDs don't go through the kind of rigorous rehab and disciplinary process. That's just my anecdotal understanding. So that's number one. I would also like to have us consider that DUIs for RNs that are unrelated to work, that they not come to us, that they be removed from consideration. So that if you have someone who is not having on a work day and they get a DUI, that those just no longer come to us, but that if we have people who show up at work and they're high, if they're on their way to work or they're leaving work, that those would still come to us. And I think it would also be interesting to look at what happens with MDs and with other people that fall under the Board of Consumer Affairs to see how other, groups deal with those kinds of things. I mean, I was licensed under the DCAI because I had an LCSW. And there was never this kind of discipline for LCSWs. Now, I realize we're not doing direct patient care, but we are providing services to fragile populations and to children and the elderly. And so, anyways, that's an aside. But that we allow the criminal proceeding to deal with those populations separate. And then the other one is that if we have an RN who ends up involved who is high at work, on their way to work, on their way home, or if that's a no-go, but they are involved in criminal proceedings and they have to go into rehab and they have to do support groups, all the stuff that we see on the disciplinary ones where the criminal justice system has all the things they have to do that are so similar to what we then duplicate, that I would suggest that they shouldn't need to do it again. We look at other kinds of ways that we look to see if nurses are safe to practice, but we don't necessarily, if they complete their judicial requirements successfully. I just personally think it's expensive and unfair to have them do it again, which is what we do now. So those are my 4 things. I hope they're appropriate. I hope they made sense.
Just for one point of clarification, just because I do hear this in my day-to-day, DUI does not just mean I had a couple drinks at dinner and I'm driving home. Some of the DUIs that we take a look at are they drank a pint of vodka in a patient's room, an empty patient's room, and then they got in their car and they drove home. Or they passed out in a jack-in-a-box drive-through and they have diverted medications in the car with them. So DUI is a broad term, so I want to make sure that just so the public understands that we're not always taking action on a simple DUI where they blow up 1.0 and they had 2 drinks at dinner and they drove home. Those are typically handled differently and they don't always proceed down the disciplinary route. So just a clarification as this is out in public that we're talking about. We will take that into consideration. We'll look at any of the legal ramifications that we have to align with. We'll look at what DCA aligns with as well, and we'll see what we can do to put forward.
I appreciate that clarification because I mean the totality of it.
Yes.
Thank you, Vicki. Any other questions or comments from board members?
Yeah.
Vice President Neil Patel.
Patel here. I have my comments written down, so, just so I can ensure that I get it the way I thought about it. But I would like the board to consider 2 changes in the sunset review. First, eliminate outdated supervision and standardized procedure requirements so APRNs can practice fully under the consensus model. We heard about the consensus model yesterday. I don't think we're fully implementing it as it was meant to be. To incorporate that a little bit further. And second, give our existing APRN advisory committees real authority in shaping scope and regulation. These 2 steps will expand patient access, improve safety, and modernize California laws. Just as the APRN roles that I was appointed to, I think there needs to be a little bit more emphasis on the APRNs here in California to really provide access to care for Californians, because I think that isn't being tapped as well as it should be.
So I'm going to address both of those. The first one is the use of standardized procedures. Standardized procedures are written in there for any RN to work into the realm of medicine under specific conditions. It is not limited to an APRN. APRNs utilize the standardized procedure in various ways. The nurse midwife has had that removed. They do not use a standardized procedure, but anything beyond their current scope of, and I could read it if you want me to, but I won't go into that. They do it on a kind of like a policy and procedure, an agreement. And again, I'm not using the specific language in the law. We're trying really to kind of do to more plain language to kind of help to explain that. And so it doesn't mean that it doesn't exist for them. They have the opportunity to use that. It's not a requirement for them to use that. CRNAs do not use standardized procedures to administer and provide anesthesia services. So that is not something that is utilized by the CRNA as well. The nurse practitioner is the APRN that utilizes the standardized procedure the most. So currently in the state of California, after graduation or initial licensure into California, if you endorsed in, you do have to use standardized procedures for the first 3 years while you complete your transition to practice. Once your transition to practice is completed and you move to a 103, standardized procedures are no longer needed. So in those examples, we have a midwife that does not use standardized procedures. We have CRNAs that do not use standardized procedures. We have NPs that use standardized procedures only for 3 years after initial licensing. And then we have the clinical nurse specialist that does not use standardized procedures for their work. So with a statement that comes to us that says we need to standardized procedures throughout the APRNs, that's an inaccurate statement and not something that we can pursue. So standardized procedures are used by all RNs. Every APRN has an RN license, and that is utilized, say, and I can talk about when I was in my practice. I was a labor and delivery nurse, and I needed to be able to remove epidural catheters after it was completed. So at the hospital I worked at, they did a standardized procedure in place. They competence validated us, and I then, as an RN, not an APRN, was able to remove that epidural catheter, check for completion, signs and symptoms of infection, and then move forward in an area that did not have the level of service that we needed. With having CRNAs and stuff on staff, we needed more of them. So removing standardized procedures halts a lot of RN scope of practice, not just APRN. So that would be something that I would look at, knowing our rules and regulations, and I would not put that under sunset to ask for removal of standardized procedures. And I would then do explanation and education like this in the same manner, just to say that that is something that is utilized in many aspects, underserved populations, rural areas, to allow for RNs to provide a service that may not be available there if that was not available.
Sure, and my aim is mostly, based on APRN scope of practice.
Yes, and so as you heard with APRN scope of practice, CNSs, CNMs, CRNAs do not use standardized procedures to practice, and NPs only within the first 3 years of licensure in California use that as they complete their transition to practice.
There's an application process and a whole process for them to then not have to utilize standardized procedures. It's just not automatic.
Correct. It is not automatic. That was a AB 890 we're very familiar with.
Yes.
And then there was a cleanup bill that just went through last year. That is not something that, again, that I would put on sunset. There may be other stakeholders that might ask for that. I would recommend to our board not to put that on, because that is a volatile conversation that happens within there. And what happens with sunset bills or any bill is, as it moves through the process, if it gets to a point and we think it's good and it goes to the governor can't veto one section. They have to veto the entire thing. So if there's something controversial that makes it to the level of the governor, and the governor then decides to veto, we sunset because there's something controversial in our bill. So that is something we would want to avoid. Your second statement about APRN committees, they are an advisory committee. They do not have power. End of discussion with that. They make recommendations to our board. Our board is the policy setting committee that we work with. So APRN advisory committees will not have the same power of the board. That's how it's set up to work. So I hear them on that. I understand that that's an ask. Each one of our advisory committees at this moment are working on regulations for our advanced practice, including even our NEWAC that is not advanced practice. They have put forth recommendations on simulation standards. Our board has accepted the standards and they agreed to have staff look at writing regulations. The regulatory authority that is given to us as a board comes from the Office of Administrative Law. It's a very clear process. That is not a process that is given to our advisory committees. Again, they can make a recommendation. Our board then makes the decision. Once the board makes the decision, staff start to work on it. And staff work with subject matter experts as well as taken into consideration with that. We work with our legal, we work with DCA regulatory legal, and a lot of times where there is confusion is when we cannot pursue regulation because we don't have statutory authority. And that doesn't mean we don't have statutory authority to write regs, we absolutely do. Our regs that we write must be based on statutory language that has been given to us through the legislator. And that is a key issue that has happened this last year with our CRNAs, is we did not have adequate statutory authority to tie regulation to. Our hope, as our board did take the position of support, was that this current bill makes it through the legislative session and is signed into law. And come January 1, we will have new statutory authority that will allow us to update our regs in an appropriate manner. But I will have to again push back that I probably will not be putting forth that APRN advisory committees have any kind of power. That belongs to our 9-member board.
Okay, and that makes sense. So let me restructure my question and perhaps consider maybe having a separate division for APRNs. So we have the division for IEC, we have division for, different things that the board does, obviously, right? Licensing and things like that. There's the nurse practice committee. There's various AP advisory committees, but having a separate division to ensure that these regulation writings, things like that can be processed more smoothly. Because as you just mentioned, there's 4 advanced practice specialties that work completely differently, right? And their advisory committees have different asks and roles, and the nurse practice committee can just do so much, as you've just mentioned. So perhaps if we have BRN staff, have a separate division to help facilitate and, regulation writing and things like that. Maybe we can have that considered in the sunset review process.
I'll provide additional clarification. Again, I don't think that'll go in sunset, just so you know. So our nurse practice committee that you chair, the statement that goes with that in the charter starts off with, it advises the board on matters related to nurse practice, including common nurse practice and advanced practice issues related to nurse midwife, nurse anesthetist, clinical nurse specialist, and the nurse practitioner practice. The committee also reviews staff responses to proposed regulation changes that may affect nursing practice. We have that authority already that lives in your committee that you chair. If that committee you want to see grow and be more robust, we do that outside of regulation. We already have the authority to do that. We do not need to move forward with that. Additionally, if you're looking at a division within the BRN staff to work on that, we do. We have a chief of LEDGE that oversees the regulatory process. We have a regulatory analyst. We have myself. We've got Reza that helps with regulatory language. And in DCA, we have a complete regulatory legal team that addresses all of this. Once we're able to get it through that area and it goes out to public comment, it goes through agency review, it goes through OAL review. There is a specific process that is already set within the government here in California that we have to align with and follow. If what I'm hearing expressed from stakeholders, from public, is they want more influence into what is written on those regulations. We do have stakeholder meetings, absolutely. That is the pathway in to get that. We do have our advisory committees. We do have regulatory subcommittees that we're working with that. We will always have areas that we don't agree on and don't move forward, because our advisory committees are made up of licensees that are practicing the profession, and they rightfully so, as I would as a practicing RN, want to promote the profession. That is not our role as the Board of California Board of Registered Nursing. We are actually not here to protect our profession. We are here to protect the public. And we will kind of butt heads on that sometimes. And so if there's ever a moment, and the case in point this year, where it looked like promotion of the profession was what needed to be addressed legislatively and not public protection, that is when it was discovered, when looking at statutory language, that the CRNA organizations were the ones that should pursue legislative language outside of BRN and DCA. So that is why the bill that went through was not co-authored by us or sponsored by us. We took a position of support because that needed to come from the organization, because it was clearly promotion of the profession versus public protection. So even if there's kind of a gray area where it says, you know, it is ultimately protection of the public because of access, correct. But anytime there's a gray area, it defers to the organization and does not live with us, because we can't, as a governmental agency, have a shadow of a doubt that we did not do public protection. And in fact, it looked like even we did promotion of the profession. Thank you.
Thank you for that clarification.
And sorry, I don't mean to negate each one of our board's requests. It's that is a very difficult position to be in, as you guys are all my bosses, and I'm like, no. So understand that there are sometimes reasons why we can't move forward in a manner that you guys might want us to move forward.
Thank you, Lori. Board Member Ellison Corbett.
Thank you, President Trujillo. So what I'm wondering about is, Sunset is primarily about the school approvals. You said
no. So the sunset issues that come forward historically
have been about
primarily been around school approvals, but our sunset can be anything.
Okay.
That's under our NPA.
Okay. But recognizing that that's a perennial issue, I guess, would be a better way to phrase that. As we've gone through this, you know, I've been here a couple years now. There are often pieces of data that we don't have because we don't have the authority. Are there two things you have in mind that would help us have better information to make these decisions that you're thinking of bringing forward in the Sunset Review?
Yes, and so one of those items was mentioned in our strategic plan for schools, and that's getting those quality indicators that were written into the various reports from National Council of State Boards of Nursing, looking at those quality indicators and bringing those forward. And if we can't get that picked up in Sunset, we would love to have that approved by our board at a later date, where we ask for regulatory permission to move forward and explore that. That is data that is looking at attrition rates and setting minimums, et cetera, where right now you guys are able to consider them, but you don't have a minimum standard that we can hold them accountable to. That's not just for pre-licensure. So APRN programs, we approve one legally, not legally. We approve one as required. We approve another one as an option. We can look at another type of APRN program to say, do you meet our standards? And then we have one that we have no ability to look at all. So of our 4 APRNs, CRNA education is not looked at by us at all. They only come in licensed through national certification. So that is one process in. Our nurse midwives can voluntarily ask for their program to be reviewed against standards that we have set in regulations. Right now, it's only 2 schools, so it's an easy process for us to manage. But that allows them to obtain initial license on completion of the program without requiring national certification. The nurse practitioner, we have a specific regulatory outline that they have to meet. They get scheduled visits. They must maintain accreditation, but they also have to follow our standards. And it's a big workload for our NECs. And that is something that we do. Again, that allows for nurse practitioners to be licensed in California without national certification. And then we look at our clinical nurse specialists where we have no regulations that are written at this point. We do not oversee their nursing programs, but we do a cursory review if they ask to make sure that aligns with licensing and make sure it aligns with the ability to license outside of our state through national certification. We don't require national certification for licensure in California for CNSs as well. We are the only state in the nation that allows for licensure of APRNs without national certification. So that could be something that the board may want to consider to pursue to align with the rest of the 50 states to require a national certification for licensure. Some of the recommendations that have come out of NCSBN as well is that we don't necessarily oversee the academic part of the APRNs, that maybe we look at outcomes and we manage and oversee them based on their outcomes. Again, looking at quality indicators and such like that versus saying your faculty must be this, your hours must be this, and leave that up to the national organizations. That becomes kind of complicated because in some of our APRN roles, there are many national organizations that they use. The CRNA one that was referenced here is one organization, one national certification. It's easy to kind of defer to that. So there are a bunch of nuances that come in with that. One of the other things with our school approval that could be helpful is looking at where we overlap and streamlining that process better.
Right.
And that's something we're always willing to do.
So when I listen to you talk about that and I think about the strategic plan yesterday, it sounds like being fair and consistent,
Yep.
which is part of our mission, that it would be important for us to do that with the APRNs, and then transparency, right? That is a value that we hold that is crucial to the public, maintaining their faith, trust, and integrity. So thanks for that overview. I look forward to seeing what goes forward.
Thank you.
Yes. Vice President Neelu Patel.
Sorry, one other thing. Vicky's nodding her head at me because I'm a glutton for punishment here. I recently attended a committee meeting for APRNs on boards of registered nurses across the nation, and I was really surprised to hear how many APRNs sit on various boards. For instance, Alabama has 3 APRNs, Alaska has 2 APRNs, and there's just little me over here trying to do what I can. Obviously, overseeing RNs altogether, but with emphasis on APRNs on some things. But I was just wondering if that could be potentially considered as we grow our board. We are not full yet. We still have one other position that's open, but something that we consider in the future of growing our board.
In order to get equal representation for each APRN, that would be 4 APRN positions on our board. That would increase us from a 9-member board to a 13-member board. There's additional stakeholder feedback that we received that says we have an education representative here, a Jovita, but they want a director of nursing or a president of a college or university to serve on our board. So then that would be 2 education. So that would bring it to 13 it'd bring it to at least 14. And continuing on that. So if we had a 14-member board, if we answered that call for everybody, that has brought forth that we want additional representation, we would have 14 members, 10 of them being RNs and 4 people being public. I can tell you we get a lot of feedback saying that we don't have enough public representation. And in fact, the public believes it should be flipped. It should be 5 public members and only 4 RN, because they believe that it should be managed more by the public because it's public protection and not promotion of the profession. And so if we had a 14-member board to answer the RN call, you would then have that as 10 would be RNs. So then you would need 11 to answer the call of the public protection standpoint. So then we would have to have 10 RNs and 11 public, which would make this a 21-member board. So at that point, this has been the makeup of our board for years. It seems to have functioned very well. Our last APRN representative was a nurse practitioner and managed that role for several years. And I think, Nilu, you are just starting. I think you're going to do a fantastic job. And I truly believe that you will represent all 4 APRNs in a very eloquent manner, and definitely represent all of their concerns as our board member looking at it the lens from public protection. So if there are stakeholders out there that want to pursue asking for additional representation on our board, please contact the legislation representatives for that. That would probably not go forward from our board because it would look like we were doing favorites and just pushing forward that versus answering all of the other suggestions that have come to us.
The only thing I would add to that is research has shown the right number for boards like this are between 8 and 12.
We nailed it at 9. And we're sitting at 8 right now. We're just absent 1 direct patient care member. And I'm sure they are constantly looking to recruit that person.
Although I would disagree with the people who think we should flip the public, because I think not having the nurses makes no sense to me. Just makes no sense at all.
And I just want people that are on this webcast to understand that came from a public member, not an RN.
Yes, I am a public member.
Thank you, Vicki.
All right, any other questions or comments from board members? BRN moderator, can you please take us out to public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." The question and answer feature is Slido, just for your reminder. Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Melanie Rowe would like to make a comment. 1 second, please. Melanie, on your computer, there should be a pop-up that says unmute me.
What about?
There you go.
Okay. The third time was the charm. This is Melanie Rowe. I'm a CRNA. I'm also the practice director for the California Association of Nurse Anesthesiology. I really appreciate that this is a agenda item for today. Also appreciate that the 4 advanced practice advisory committees have sunset on their agendas as well. Executive Officer Melby, I want to push back on your pushback, please. As a CRNA, I'll just focus on our advisory committee. I see that there are 4 CRNAs and 1 public member, and I don't see that the advisory committee is seeking power, but we are literally the subject matter experts for the profession. So with only 2 meetings a year, it clearly needs to be that the CRNAs and the public member have discussions that we can bring to the practice committee. So in the, 3-4 meetings that we've had since the inception of the CRNA Advisory Committee, I personally don't see it as seeking power, but being able to have a voice with only 2 meetings to be able to express and bring all the issues that we need for our profession forward. And then regarding controversies and sunset legislation, this really confuses me because I think the only people that would cry controversy in nursing discussions would be physicians. And I really think that when we see the medical board or the dental board in their sunset review, they do not worry about what nurses are thinking about what their professional business is and what their sunset is in creating. And I really do think that as we increase access to care and we help health facilities in achieving their goals and seeing as many patients as possible, we are achieving the goal of the Board of Nursing in protecting and protecting the public and not advancing a profession. I mean, these are our goals. Thank you.
Thank you. So stay on because I'm going to address this. And if you have any additional questions, I would love to engage in that just a little bit.
Thank you.
So the reason I said power is only because Nilu, when she mentioned that, said that the advisory committees would have more power. So that is why I used that term. Not that I think that any of our advisory committees currently are asking for any kind of a power. I just was responding back to what was presented to me. APRN committees do meet twice a year. We have 5 APRN committees, and because of that, we hold 10 additional meetings a year, in addition to our 4 committee meetings and our 4 board meetings. That is 18 meetings a year that we hold open to the public to have this information brought forward. That is a huge load on our staff, as well as just time taken to hear the voices of all of our advisory committees, all of our public. And we do that because we want to hear from everybody. It's not a negative thing, but I need to sometimes share numbers so that you guys can understand what we're doing to make those accommodations. 18 individual meetings. That doesn't count our other pseudo-advisory meetings, which is our Intervention Education Committee. We have 9 of them. They meet 3 to 4 times a year, depending on the need. And that is another, almost 30 meetings that happen that our board holds. So if I were to add that up together, we're pushing about 40 meetings a year that we hold open to the public to allow for public comment, to allow for input from all of our licensees in all of the areas that are important to each one of them. We are very public focused, very stakeholder engaged, and we plan to continue in that realm. Each one of our advisory committees, there are 5 of them, do hold 2 meetings a year with an option to add an additional meeting. This year, you were able to see that we added an additional Nursing Education Workforce Advisory Committee in June. We did that over and above what we are asked to do, and we did that because we felt that it was absolutely necessary. In years past, we've had the Nurse Practitioner Advisory Committee meet 2 or 3 more times when we were looking at writing regulations and passing regulations. That was effective at that moment, but when we looked at that structure and whether or not that was something we were able to maintain, which we were not able to maintain, which is why we went to the makeup that we currently have now, where there are subcommittees assigned to each one of our advisory committees, and those subcommittees can meet daily if they choose to. It is up to those professionals on those advisory committees to take that and move forward with it. They can meet with any stakeholder that they choose to. They can meet as a subcommittee every day, all day, if that is what they choose to. There is no limit for how many times they meet. Those subcommittees, when they are developed and run effectively, are required to bring back any of their work to the 2 meetings that are held annually. That is a report out, and that is where they report as a subcommittee of what they have been working on. If they have a final product, we don't just have them report out, we agendaize that final product and we move it forward. An example of where that subcommittee worked very, very well was the simulation subcommittee on the Nursing Education Workforce Advisory Committee. They jumped in, they moved the regulation recommendations as well as the simulation standards through. They brought it as a subcommittee to their committee, reported it out. We did a separate agenda item for it. They made a motion that day that said, bring it to the board. We brought it to the board. The board made a motion, accepted it right away. It was a very efficient and effective subcommittee, and they were able to move that quickly. Each one of our subcommittees of each one of these advisory committees have that same ability to do that, and they could run those through independently and be just as efficient as our simulation subcommittee was. We have offered up our assistance to that, and we have even gone and reached out to them to try to facilitate the meetings. We are not required to be a part of those meetings. We are able to work with them if they invite us in. We always offer our service, but that is an area that can be worked on by our subcommittees, by our advisory committees, as well as us BRN. We're not doing it perfectly yet. I don't think that needs to be addressed in statute because we already have a process in place outside of statute and it's working. It just is new. So I think it just needs time to become more effective. But just to clarify that the subcommittees that we asked to do the work of the advisory committee can meet unlimited amount of times, and with any stakeholders that they choose to. We just ask them to report out and any specific agenda items to move through. I know that APRNs right now are a very large focus, and that is because they haven't been a focus in the way they are today for many, many years. But I do need to do kind of a statistical check. We have over 550,000 RNs. Only about 10 to 12% of that population are APRNs. And only 0.6% of our population is a nurse anesthetist. And very important, which is why you guys have been at the forefront of our population and of our focus, even though you are a very small population this entire year. And we plan to continue that. So I don't want to make you feel like that's diminished, because it's absolutely not. That CRNAs are a huge focus, and we're doing what we can to support you guys through this last year and advance you in your processes moving forward. But I have to look at it from a total board perspective and a total licensee perspective. And with APRNs only being about 10 to 12%, I also have to balance that with, 88% of other issues that are coming in. So you may feel like you're not represented fully, and we felt that clearly, which is why we, out of a statutory requirement, did establish a CRN advisory committee as well as a CNS advisory committee, because in statute we had a nurse practice advisory committee and a nurse practitioner, and a nurse midwife advisory committee. We wanted that equal kind of makeup. We did mirror the population kind of setup of each one of our other statutory advisory committees, and as said yesterday, without the addition of the physician members. Yes, Melanie, your statement that some of the opposition that we do receive in any of our legislation, including sunset, does come from the physician and surgeon realm. It does. That, again, is welcomed feedback, and it's managed typically through the legislative process. That's not something that we can take away. We will always have medicine providing feedback to nursing. We will also have public providing feedback to nursing outside of medicine, outside of nursing practice, and we just have to manage through that. So if I answered everything, Melanie, I hope I did, but if you have clarifying questions, please feel free to continue to ask.
I really very much appreciate the time. I do want to add that I never attended a BRN meeting when I was an RN, but definitely you have seen me representing as a CRNA. So I definitely do recognize that. And in my day job, I definitely do try to mentor RNs and explain to them what I'm doing when I'm not at work, so that they also will be more engaged, so that they also know that all the work that you guys are doing, for the public's behalf, but also as licensees of this board. And so just if I can clarify, so these subcommittees can meet daily with any stakeholder, and then the BRN executive staff is also available to meet with these subcommittees so that more work can be done in between these two public meetings.
Correct. I can't say that I can meet daily, but I
Oh,
do
yes.
try to meet. I do try to meet as frequently as asked. And so if there is a need, I do try to clear my schedule and set times so that I can meet. You guys hear that in my EL report outs, that I try to meet with as many stakeholders as possible. So yes, you are accurate. Subcommittees can meet as much as they want to meet. There is no limitation to that. It does not violate Bagley-Keene, and they are free to reach out through Macaulay to set up any kind of BRN staff that you might want to be in that meeting. Sometimes it's asked for Reza, our board counsel. Sometimes it's asked for me. Sometimes it's asked for Marissa, our chief of ledge, to be in there. And sometimes they just want Macaulay. So we are available. It has to come from you guys as an ask. And it looks like Macaulay's looking at me to say something. Do you want to jump over? Yeah, sorry. And just so public that isn't familiar, Macaulay Fusarens is our chief of licensing and the doer of everything, honestly.
Sometimes feels that way. I just want to say too, I can help coordinate meetings with obviously BRN staff, but with some of the other advisory committees, they have requested just kind of help scheduling between the subcommittee groups. So that's always an option as well. They can just reach out to me and I can help get things on their calendars that they can kind of forces them to kind of have something on a regular basis. So if they need help, they can reach out.
So I feel like my job today is to push back on everybody. Macaulay, no.
So we got to do that for everyone.
I love that you want to facilitate that and help. I have so many other things that I need you to work on. We try not to be involved in the subcommittee scheduling, right? If you are involving the BRN executive staff, absolutely bring in Macaulay and she will help facilitate because she has access to my calendar, her calendar, Yvonne's calendar, Marissa's calendar, whoever needs to be in there, she has access to, and she is the liaison for our APR and committees, and she absolutely can help facilitate that. But if you're just wanting a standing item on your calendar, I'm sure you guys are completely able to do that. I appreciate you wanting to help, Macaulay. I love that about you, but I'm going to have to say no to you too.
I'm okay with that, but I just wanted to be equal because we have done it for some of our advisory committees.
We have an initial startup. And so if there are new subcommittees that need some help, we are absolutely willing to help you on a startup, but we want to remove that process from us as quickly as possible as soon as you guys know how to manage that yourself.
Member of the public would like to make a comment. 1 second, please.
Can I just say something, just a point of clarification, because it was brought up that I said power. I actually didn't say power. I said authority, and it's a good thing that I.
Sorry.
And just to imply that the authority could, having the recognized statutory role in shaping regulations, the committees already exist, and they're the expertise, like Melanie had mentioned. So giving them the authority simply ensures that evidence-based input is directly coming from them.
And so just for clarification, thank you for clarifying that for authority. Authority is power at this point. And so I know we're kind of splitting hairs, but our advisory committee does not hold the authority. Our board does. And we just have to make that clear delineation.
Thank you, Lori. Any other questions or comments?
We have
board
a public member that wants.
Well, because these are
sorry.
it. So, all right, the moderator, please continue to open this up for public comment.
Oh, thank you. Yes, I wanted to actually comment on Board Member Patel's comment. I agree with it. I do feel like there is an absence of advanced practice membership or representation on the board as far as let's say, if we're going for weight as far as the nurse community, let's say, there are 4 types of advanced practice nurses, and there are growing numbers of advanced practice nurses. And I appreciate you, Nilu, bringing this up. And I think that it looks like, looking at the board, aren't we down a few people? And when we grow people on the board, I would advocate that we add nurses and that we add advanced practice nurses. I agree with you. Thank you for bringing this up, because I agree with the person that spoke before me that, and I think you might recognize my voice, but as a member of the discipline community in advanced practice discipline needs to be looked at, please, because I might have one more minute in my comment. I think that we need to look at adding a part of the discipline that goes for those who could not finish probation. They should be allowed to retire like physicians, because otherwise you are forever shunned. You cannot work anywhere because of the National Provider Database. You're forever hurt, and physicians are allowed to retire. And this is a very big issue, and I can't even talk about it because it's so difficult. Thank you.
Appreciate your feedback. Yes, we do recognize your voice, but that's a great thing. Honestly, you continue to show up, you continue to provide feedback. We welcome that. I've heard your voice in advisory committees as well as our board committees and our board meetings here. So please continue to show up. Please continue to ask the questions, seek clarification. I, for one, appreciate it. So please continue to do that. We do have one vacant member on our board that is a direct patient care member. Our board members are not appointed by us. We, as the Board of Registered Nursing, have no authority in who comes and joins our team. We have 5 people that are appointed by the governor. This is a governor appointee that we are waiting on. We do think that we will get a governor appointee at some time soon, but I know that he has been otherwise focused recently. Additionally, the 4 public members do come equally, 2 from the Senate and 2 from the Assembly. And they, again, are appointed outside of the Board of Registered Nursing, and they come through us that way. So we have no authority in who comes to us or how the makeup is. The current makeup of the board is established in statute. And yes, that could be changed through our sunset process. Again, that is probably not a suggestion that will come from our board to change that makeup, but that is something that can be brought forward from the public to the legislative representatives. And if the legislative representatives decide to pursue that, that is language that can be added by them.
Melby, may I add a clarification? This is Board Member Cormack. When we all do our introductions, of the 4 public members, 2 are appointed by the governor. So it's 7 of the 9 potential are appointed by the governor, and then 1, and Rez is going to correct me if I'm wrong, and then 1 public member, it happens to currently be Board Member Granowitz, is appointed by the Senate, and then 1 public member happens to be me currently, is appointed by the Assembly. So 7 are appointed by the governor. All 5 of the nurses are appointed by the governor. And I will be corrected if I'm wrong.
No, you're correct. I misspoke. Thank you for that.
All right.
Thank you for
Any
your
other
comment.
questions?
I was just going to say, Board President Trujillo, there are no other public requests for comments on the WebEx. And do we have any in-person representation requests for comments there?
We have 1 person.
Perfect.
Yeah, thanks.
Good afternoon, board members, Monica Miller. And today I'm representing two different entities, the first of which is the California Association of Nurse Anesthesiology and the American Association of Nurse Practitioners. And first and foremost, I really want to thank you for this opportunity to have this discussion today. We do hope that there are additional discussions moving forward. As you know, sunset's a really big deal. There's a lot of issues that both providers are dealing with in the healthcare field. Healthcare is definitely under attack right now. And between the provider shortage and what's happening at the federal level, we're very mindful of how that's going to impact future generations as it relates to healthcare. So we hope that you obviously do get your sunset extended. We think that that would be a good thing, preferably for 4 or 5 years, but definitely want to continue to work with you and your staff who is wonderful, by the way, your staff and your board on these issues as we move forward and continue to have these discussions. So we do hope that there is an opportunity to talk both at your level, and then of course, obviously, we'll be talking with the legislature. And thank you for your opportunity today and your time.
Yes, thank you. We do have it on each one of our advisory. We did add it to our board. This information will come forward. And again, remembering that our report will be presented the first time in October to the Nurse Practice Committee, because they do look at RN practice as well as APRN, all 4 APRNs. And so we felt that that was the lens that it should go through first. And then it will be represented based on the edits from that practice committee to our full board in November for hopeful acceptance of it. It may get to our full board by November and they may ask for a complete rewrite. I hope not. But then at that point, come December, we will go ahead and hold a special meeting to get that approval, because it does have to go forward to legislators by January. So continue to provide input. You're free to email me. We will collect it. I will share it. Or even McCall, you can reach out to her. She's going to help write the sunset report with me and Yvonne. And we will take all of that stuff into consideration. We may, as we collect this data, if we start to get things that are just beyond our jurisdiction or cannot do that, we will set those aside. We will draft a response to that and get that out to you guys so you know why it didn't move forward, because there are some times where if it's not within our NPA and there's an overlap, you won't see it come forward, but it doesn't mean we didn't hear you. It just means we have no authority over that. Thank you.
Thank you. Do we have any others?
No, it doesn't appear that we have any more requests for public comment here in HQ.
Perfect. Would you like me to close this window?
Yes, please. Thank you.
That's it.
At this time, this concludes our meeting for today, day 2 of the Board of Nursing board meeting. We are adjourned. Thank you, everyone, and have a wonderful afternoon.